Hi, everyone. It's good to see people coming in. Hopefully we've got a little bit of time for people to come into the webinar. But hello, welcome to the session today. My name's Nathan and I'm from the European Pain Federation, and I'm joined today by several speakers who you might be able to see on your screen now. And we're going to discuss several topics, and we're going to be taking questions related to the management of pediatric pain. We'll touch a little bit on treatment approaches and also resilience factors and their roles in buffering pain. And in a few minutes, I'll give the chance for the speakers just to introduce themselves and give you a little bit more information about their expertise and their experiences. Just with regards to the session today, as I mentioned, it is a Q&A session, so please feel free to drop some questions into the questions section, which should be at the bottom of this window. So double check that. This is an interactive session, so your questions are obviously welcome. And of course, it's a great opportunity to ask questions directly to the speakers who will be with us today. There's also a chat function for general discussion, so feel free to pop in any comments in there, any notes. That's absolutely fine. I would also encourage between the speakers questions to each other to sort of facilitate a general discussion, because you know we're all looking to expand on our thoughts and stuff, so that would be really great. It'd be great to get a discussion going and sharing views, and I think there's some really interesting topics that we can cover today with input from everyone involved, which is fantastic. So perhaps maybe we could start with letting the speakers introduce themselves and maybe give a summary of what they can remember from their talk that they gave on the EFIC Academy platform. I'll kind of go in sort of clockwise view from my view. So maybe we could start with Emilian. Welcome.
That's me, I guess. Yes. Yeah, thank you. In Flemish, we pronounce it a little bit differently. It's like Emmeline, but that's no problem at all.
Emmeline, I've got this. Yeah, don't you worry about that.
No problem. Yeah, hi. I'm a clinical psychologist. I'm a health psychologist. I'm working at Ghent University, partly as an assistant professor and also as a postdoc within two faculties, the Faculty of Psychology and also the Faculty of Medicine and Health Sciences. And I've always been doing research on, pain and coping with chronic pain. And that's still one of my research topics. I'm also doing some research on how it is for breast cancer survivors or cancer survivors in general to cope with complaints like pain and fatigue that don't go away, in fact. And we developed some interventions to assist them with this, and also to train healthcare professionals a bit more in how to assess pain timely and also treat it using a biopsychosocial perspective. And besides that, I'm also doing some research on stress and stress-related disorders from a primary prevention point of view. For instance, we try to kind of unravel how students, medical trainees, cope with their studies and how they prepare before becoming a full-time healthcare professional. In fact, we study some resilience trajectories. So resilience is really a concept that I'm doing a lot of research on in different contexts.
Amazing. Yes. Amazing. Welcome.
Yeah, what I can remember from my talk, it was on coping with chronic pain and about the finding a balance between trying to solve pain and the usefulness of taking another approach, like trying to accept the problem of pain in some kind of way, and resilience is a really related concept in that respect.
Mm-hmm. Fantastic, thank you. And Ricard, welcome.
Thank you. My name is Ricard Wicksell. I'm a clinical researcher from Stockholm, Sweden. I have a position at KI as an professor of clinical health psychology. And I'm also a psychologist and head of research at the pain clinic at a hospital in Stockholm called St. Göran. I've been working with kids and adolescents and adults with chronic pain for about 20 years now. I started with kids that struggled with chronic debilitating pain, and then went on looking into how we can develop a model based on behavioral interventions and acceptance and commitment therapy for these individuals, essentially in order to improve resilience and improve functioning in these kids, even if pain is not always addressable by itself. We then have been doing a lot of different things that are related, looking at biomarkers, for example, development of different instruments or measurements, looked at different types of interventions, group interventions and individual interventions. Lately, we have been focused a lot on digital health and digital interventions to both increase accessibility to evidence-based interventions, but also to develop better opportunities for research. We can look into mechanisms, and we can, for example, assess daily the type of measures that we are interested in. For example, looking into how resilience, symptoms, and functioning are dynamically interrelated over time. So that's a big part of what I'm doing today. And I'm kind of going full circle. So I'm kind of coming back to the pediatric chronic pain field and find that to be kind of a little bit of my home in a way. So it's very nice to be here today, and I look forward to the chat.
Great stuff. Managed to find a way back home. Always great. Always great. Thank you for that. Lena, perhaps you next.
Yes, thank you for inviting me to be here today. So my name is Lena Kaas, and I'm an associate professor at the University of Stirling in the Division of Psychology here. And I do apologize if you can hear the background noise. It's Easter holidays, so I do have my toddler running around in the background. Yeah, we'll do the introduction together. So my work mostly looks at pediatric pain, but with the social context perspective. So mostly looking at how parents are responding to a child's pain experience, and how that response of a parent is influencing then the pain experience of a child in return. And I actually started my PhD at the University of Ghent together with Emmeline. And during my PhD, I mostly focused on acute pain and acute pain experiences. Some of these were repeated pain experiences like lumbar punctures or bone marrow aspirations, but it was mostly focused on acute pain. And then post PhD, I kind of moved into also exploring this kind of parental role in chronic pain experiences. Found kind of my niche there, where I'm really interested at the moment, and really focusing at the moment in adolescents, dealing with chronic pain experiences, and how the role of parents there is kind of oftentimes a point of conflict or discussion, because the adolescent wants to become independent but still needs support from their parents. So how can we navigate that? And also looking at the role of things like executive functioning that is developing in the adolescent, which is relevant for self-management of chronic pain, but is also still developing in the adolescent. So I've really become, in the past decade, focused on chronic pain experiences in adolescents, because it's such a tricky time of development to experience chronic pain, and how can we support them as best as we can.
Amazing, thank you for that. And your young one is more than welcome to join in. More than welcome.
Yeah, she'll probably pop up every now and then.
No problem at all. And last but not least, Megan, welcome.
Welcome, good morning or good afternoon to wherever you are. So it's just after 6 a.m. my time, so no one else is up, Lena, so you won't hear my son in the background. So I'm Megan McMurtry. I'm an associate professor at the University of Guelph in Guelph, Ontario, Canada. And I'm a clinical and health psychologist with the pediatric chronic pain program at McMaster University. And so I run in our pediatric pain health and communication lab at the university. We started with looking at sort of parent-child interactions during painful medical procedures, because that's where I had done my PhD. as well, or that's the focus I had. And really what I've tried to do over the intervening years is really broaden to think about the communication context in more general for pain. And then also I'm really interested in how pain interacts with other factors like fear. And so what I presented on was around managing needle-related pain and fear and fainting. However, I do some work on that across the lifespan, but most of it focuses on children. And then also in my research lab, we do lots of other work, and we do, for example, helping with pain in neurodiverse populations. I do some work actually on understanding resilience factors in chronic pain myself, in pediatric pain, and all sorts of other things that we do. So, but today I assume most of the questions and what we'll talk about is around needle-related pain and fear and acute pain, but I will also probably have some things to say to add to my other panelists who are very esteemed colleagues on chronic pain as well. Thank you.
Fantastic, no problem. Yeah, hopefully we can cover all bases in the chat today. And again, if anybody's got any questions, specifically the speakers to each other, feel free to just, you know, pop them across. It would be great. And everybody watching, you can see we've got a wide range of expertise in the session today. So don't forget to get your questions submitted via the Q&A for the Q&A section at the bottom of the screen today. So perhaps to start us off, and perhaps we could go around in the order that we introduced ourselves. So Emilian first. When we mention sort of pediatric pain, how different is it to how adults might experience pain, and how important is it for us as clinicians, researchers, and perhaps caregivers? How is it important? How important is it for us to understand these differences? Emilian, perhaps you could start us off with that one.
Yeah, if it's okay, I will give the floor first to my colleagues because my expertise is less on pediatric pain and the difference with adult. I always did research on adults, within adults. So if it's good for you, if I see the space, I will pop in, but I think my colleagues have more background regarding this.
Of course, no problem, no problem. Does anybody want to jump in and just start us off with that one? Their thoughts about that?
I can
sure.
Go ahead, Ulrike.
Should I? All right. Okay. Well, I mean, I think it's kind of an interesting question because we're always assuming that there are differences and we need to adapt things we do in the adult care to match for the pediatric setting. But I think, you know, coming from a pediatric context and then working with adults, it has never really been a problem. It's kind of where your starting point. Everything is relative, of course, you know. But if we look into what we do with kids and see if we can apply that to adults, it works perfectly well. Of course, if you have something developed for adults and then try to adapt it to kids, it might be a bigger problem, and then you need to do some adjustments. But for me, starting with young teenagers, you know, everything we did was just like easily implemented into adult settings. And we know this, like we know that kids are not small adults, but we know for certain that adults are big kids. So I would say that the similarities are far greater than the differences. These are living organisms. These are individuals that operate in a context based on essentially the same principles. So from a learning theory perspective, we follow the same sort of map when we navigate in the world. So without neglecting the important aspects of working with kids, I think it's very important to not overemphasize the differences. So one thing that I would like to say is that I've heard a billion times that, it must be much easier to work with kids with chronic pain because they're not kind of damaged and broken by the life and society. And I think that's a little bit, how should I put it? It's not based on experience. Like if we look at the challenges for a teenager to make behavioral changes in accordance with their life values and long-term goals, they are within a context having a lot of people that influence their attitudes, their ways of thinking, their emotional reactions, and shape their behavior patterns. So when you address a behavioral problem, which chronic pain to a large extent is, you need to take into consideration the contextual factors. And sometimes the contextual factors primarily are like the parents and the soccer coach and the teacher, and kids that have not yet become fully autonomous. I mean, I don't think we ever will be autonomous, as adults either, but they are heavily influenced. So it might be sometimes that you work with a teenager and you struggle with having progress in treatment, mostly because of other factors are influencing the patient in a slightly different direction. So having said that, I think it's extremely important to really consider the social context and address that and bring these people on board, the parents, but I think we should not stay with the family boundaries, like within the family boundaries. We should also look into teachers and soccer coaches or whatever it is, and that's something that we are not really good at.
Makes perfect sense, and we'll touch on that a little bit later as well. But
Lina and Megan probably have wise things to say about that.
And again, any thoughts about that, Lina and Megan?
I think I could summarize it quite nicely. I think my key thing was going to be, I'm always about the social context, but I think the key thing or the key difference is the social context. Like, children are so embedded in society, and like Rickard said, it's not just the parents, but the parents are a starting point at least, and it's going to the wider family, the wider environment, to school. And I think especially on the concept of school, we can definitely improve a lot more to include the teachers and their peers and their friends and how they can support the child or the adolescent. So I think that's the key difference for me, the kind of inclusiveness of that social context. And I think it's important adults as well, but it's just a quite different social context in children compared to the social context of adults. And this is where it gets very tricky, to my perspective, in adolescents and young adults, where that social context is starting to change and peers are becoming really important, and potentially partners in young adults are becoming really important and potentially more important than parents. And it's about navigating that changing social context in treatment as well, and kind of seeing how can we navigate that and make sure we are approaching the right social context for these people. So yeah, I think that was my key message to add there.
Fantastic. And Megan?
Yeah, it's easy to go third. So I agree with what has been said. And what would I add? In understanding people's experience of pain, I think we need to make sure we're measuring it, asking about it in a way that they can understand, follow, and respond to appropriately. And so I think some key differences that we do see from like pediatric versus adult is really, how do we understand the experience of pain? Meaning, so what measures are we using? And of course, there's lots of different measures that have been developed for work with children. I think a really important area that we need to continue to work in is not only that, but also for more neurodiverse populations, for children as well as for adults, that we need to ensure that we are assessing pain and kind of the context of pain in a way where we're actually getting valuable information from the individual, from the caregivers who are involved, because I think there's lots still to be done there.
Fantastic. Yeah, fantastic. And it flows. Rickard, you had your unmuted there. Any comments?
Oh, no, no further comment on that. No.
No worries. It's a great summary. It's a great summary. And we'll touch a little bit later on in terms of, the difficulties of assessing pain in children. And a little sort of question that's come through from David says, so when does a child learn what pain is? How much is cultural and environmental affect the pain? So how much does the environment affect the pain? And perhaps when does a child learn what pain is?
Oh yeah, that's a brilliant question. I mean, I have to, I struggle to not turn the question into a large discussion regarding the language we use to describe unpleasant experiences. Well, I'm going to fail on that one anyway. So what makes me a little bit concerned when we're talking about pain is that there are very different, mechanistically different phenomena being described with the same word. So language is absolutely insufficient in helping us navigate in this complex world of pain. So for example, we can have acute pain that is a clear threat to the organism. It represents a danger to the organism. And then we have chronic pain that is definitely not a threat to the organism. It may cause a lot of unpleasant reactions, and you may withdraw from important activities, but it's not in and by itself a threat to the organism. And we're using the same word. So if we realize the symbolic representation, the implications of symbolic representations, we understand. And if we're looking into the association learning, then we realize that the symbols that are used will be very important for how people perceive their condition or perceive their experiences. So when we're using the same word that signals danger, talking about something that is definitely not dangerous, of course, we will use stimulus functions from acute pain and put that in the chronic pain basket. So we're actually inducing a threat value that is not there from the beginning. So how we talk about this is extremely important, and that goes sort of beyond the distinction between kids and adults. But if we have, young individuals, we need to be very careful in how we communicate with them. Like, do we want them to perceive the pain as something that is not a threat to the organism? Then we need to communicate that clearly. So I think this question is brilliant, but it goes way beyond sort of the terms. It goes in the direction of how we communicate about this in general. But I'm going to stop there because I know that Lina and Megan and everyone has a lot to say about this.
No, thank you. And if anybody would like to add to that, please add.
I maybe have I don't have the theoretical background, but I have a question. Hearing my colleagues talk about their expertise, I'm wondering about the difference between children and adult pain experiences. What I see in research and also in my clinical practice, pain often is a threat to identity. It interrupts not only your activities, but it also it lets people let people reflect about what they are and who they want to be and what their core values are and all these things. And often they're found stuck. I'm wondering, thinking about how it might affect children, given the fact that they're in the full developmental stage of really forming their identity. I guess, I don't know if there's any figures or from your experience, whether it affects young people more or it makes them more vulnerable, or they're more flexible in a way. I don't know. It's a question.
Mm-hmm. If anybody would like to contribute to that, go for it.
Yeah, I'm quite happy to answer that because it quite nicely fits with a PhD student I co-supervised with Abby Jordan, who did some work on identity and social development in general, but identity specifically in adolescents with chronic pain. And no numbers, there's very few studies on identity development in adolescents with chronic pain, and most of them would be qualitative studies. So most of what we know about the impact of identity, or vice versa, the impact of pain on identity, is from qualitative work. And we did see in our own qualitative work, both we had a big group of adolescents lost in their identity development, and pain was taking over, and it was all about the pain, and they were stuck and they didn't know who they were anymore. And they were really feeling lost. But then we also had a second group, which we identified as the loss adjusting group, which was really, they had that loss. They had felt lost in their identity development and not sure how pain fitted in, but they had kind of come out on the other end and had adjusted to it and had found a new personality or a new identity with the pain, where the pain fitted in the puzzle. And it wasn't overarching or over, how you call that? It wasn't only about pain anymore. They had found a way of moving forward with pain as part of their identity, but it wasn't overwhelming anymore, the pain. But definitely, and we're still continuing that work actually with a new PhD student at the moment, who's looking at identity measures in adolescents with chronic pain. How can we actually measure their identity in these samples in an appropriate way that we can identify this loss and this coming out of on the other side of the loss? So definitely an area of a lot more research needed, but a very good question.
And I guess the only thing, like small thing that I would add is that for parents, it's so challenging to help their young person know how to navigate this and know what developmental expectations they should maintain or not maintain or accommodate for their young person. And so clinically, you know, I know we see this every week. And I think there's a really important role for parent interventions as well around this. And certainly, you know, we've done some work looking, led by Sun Lee, looking at like a parent group. And one of the foci is around sort of what kind of developmental expectations should you have for your young person with chronic pain. And I appreciate, Lena, when you talked about how like everything in the identity sort of can become around pain. And that's language I often use when delivering the program. And sort of part of our role is to sort of shrink the focus, right, on pain, because it sort of gets very greedy and takes all the focus for the individual and for the family. And so as many of us are interested in this webinar, you know, understanding the family context and also intervening for parents, I think is really important in this context.
I would like to add that I don't think that this is like that when we talk about identity, I don't think that it is inherently about pain. It's about how you relate to pain and how you react and respond to pain. Because we can create a trajectory that is characterized by resilience to pain and distress. And that will imply taking actions that, you know, will result in growth. You know, I learn that I can have pain and do things that are important to me. So what I normally think is that, you know, it starts with pain. Normally, it's like it doesn't start with an identity crisis. Like it starts with a problem like pain. But when pain has a threat value and you respond to that threat value with carefulness, and you start to avoid things in a way that prevents you from getting access to the ingredients of life that is actually really good for you. You know, having friends, going to school, taking actions in different contexts, and you know, become empowered by, you know, the reward that comes with those situations and those actions. Then we can shape a resilient response to pain. And by doing that, we can also prevent that downward spiral where ultimately people start thinking about themselves as insufficient or incapable. And then it starts to nag on the identity. So I think the resilience dimension of this is key. So pain does not lead to an identity problem. It's just the start of a journey that could end up in that domain, but clearly doesn't have to. So this is what we can do as the context. You know, the healthcare context, social context is instrumental in shaping the behavior pattern, and we can facilitate growth with pain. Pain does not have to stop people from living life fully, but it can. So that's our role.
So just to add on a little bit, because I'm realizing David's question from before, and I think it connects. So Ricard has just beautifully, compellingly described the importance of our relationship with pain in a chronic kind of context, right? And I would go back also to David's question and say that our responses to pain for very young children. Young children look to their parents for when they experience an unpleasant event, and look and do social referencing, right, with their caregivers to understand it. So this learning takes place in an acute, usually in an acute context, over and over and over and over again for young children. And I should not be the one talking about this, because Lena absolutely has done work on everyday pain, right, in young children. But this just connected with me. So Lena, I don't know if you want to say anything more on that, or if I've totally bungled it.
Yeah, I was going to come back to that point as well, because we've, and you summarized this so nicely, because a lot of the, when people or children start to learn what pain is, kind of happens in preschool years and in the toddler years, by just observing others or observing your parents' responses to when you fall down. Again, I think an area where we're still starting to understand what's happening. Ines, can you be a bit quieter? I can't hear myself, folks. So we know quite a bit around the vaccination context in preschool and how they understand pain in that context, and truly look at their parents, of how the parents respond. If the parent is quite anxious and protective, the child will get quite anxious and protective around that situation. And we've been trying to do some studies around unscheduled acute pain experience, so like running around and falling down, because they're quite different than a medical context, and also experiences that children have very frequently. So those are the key kind of experiences they have with acute pain early on in life, that kind of identifies for them what pain is, how do my parents respond to pain, how should I be responding to these pain situations. But we're not sure how that then evolves in future development, and whether these experiences for acute unscheduled pain experiences in preschool years might set you up for being vulnerable for chronic pain experiences, because maybe the learning experiences weren't as optimal as they should have been. So yeah, definitely still an area of further exploration, because I think they are key. These kind of preschool unscheduled pain experiences are key for identifying what is pain and how do you respond to pain. But it might be very different to the pain experiences you have in adolescence and later on in life, and definitely very different than chronic pain experiences. So we learn what pain is by learning what acute pain is. But then later on, we have to adjust that to know what chronic pain is. And that might be quite tricky, because chronic pain is a lot different than acute pain. And if we start out learning about what acute pain is, then we have to adjust that throughout our life to understand what chronic pain is.
Yes, and that's kind of what I was pointing at in the beginning when I was like mentioning the differences between acute and chronic pain, and the problem of us using the same language to describe the phenomena that are distinctly different. And since we have our first billion experiences of pain in a context where it is normally like acute pain, well, then that's how we kind of organize our impressions, and we start to interpret it based on that context. And then when we have a similar like experience, then and the same words are being used, then that tells us this has to be the same thing. Mm-hmm. And that's, I think, where we get lost. That's where we create a threat value of something that doesn't have a clear threat to the organism. So we are confusing the patients. We are adding to the threat value of the individuals. And that's why I think this is such an important topic of discussion, because this is not being addressed in healthcare. Systematically, at least. Of course, people are aware of this to some extent, but we see again and again how people are kind of confused about the distinctions between acute and chronic pain, and react psychologically to chronic pain as if it was acute pain. And we need to understand that we add to the problem by how we talk about it. But of course, there's learning history, as you said, Lena. That's there, and then that we cannot change, but we can think about how we organize our efforts in healthcare and how we talk about the kids, because they are in a development process, and we can influence how they deal with this.
Mm-hmm. Fantastic. Thank you, guys. It's a fantastic discussion. Hopefully, David, that answers your question a little bit. So just another question that's come through. So based on your experience, which are the leading causes of pain in children? And they made a comment of organic and not. It might be a little bit difficult one to suggest, but could you perhaps suggest some of the causes of pain in children? Perhaps we could start with Rikard first, if you have any thoughts on that one.
I mean, if I understand your question correctly, I mean, a headache and stomach pain is the most common, and we have some musculoskeletal, which I find to be an ironic name because it's not problems with the muscular system or the skeleton. So I don't like the term. And that actually illustrates my previous point, that we're using language that actually puts the patient in a shitty position, because we tell them how to think by using these labels, and they end up thinking that I have pain because of problems in my musculoskeletal system, and it's not. So this is, again, maybe I'm redundant, but like this is again the sort of the problem. But the sort of general pain is also fairly prevalent, but I think headache and belly pain is the most frequent. And if you talk about like the mechanisms, like compared to adults, neuropathic pain is far less common. In kids, it does exist, but it's far less common. So I'm not exactly sure what you were aiming for with the question, but that's a start.
No, that's absolutely fine. I think based on the question that was answered, it was exactly that. What types of things might we see in clinic, and then obviously touching on the mechanisms would be fantastic. Does anybody else want to add to anything perhaps that they've seen in their own clinical experience, which might be interesting for everybody?
So sorry, please go ahead. And now I'm not going to say your name right. I'm online. Sorry.
Emmeline, would you like to go?
Emmeline?
No, I was on. You can go, Megan. That's no problem, man.
Okay, it'll be brief.
Yeah.
I was just going to say, so again, so stomach aches, headaches, if we're thinking more perhaps getting to a chronic state, maybe not. Yes or no. Lena would talk about probably everyday pains, right, that are experienced. That's very common. I would just like to add, in the medical procedure context, needles are ubiquitous, right? We use them for diagnosis, monitoring, delivery of medications, prevention, right? When we think about vaccines. So certainly healthy children undergo many needle procedures before they reach the age of 18, like over 24 easily in Canada, right? And that's if they're healthy. If they have chronic illnesses like diabetes or cancer, there's many more needle procedures. And Lena's right, these may be more scheduled, at least for the parent. I'm not sure that for children, they're always known to be scheduled, right? But it is a very different context. And yet there is learning, obviously, very important salient learning. And speaking of threat value, I mean, that's a whole other thing. So I was just going to add, in terms of the acute context, what some of the common pain experiences are and why I might be interested in needles.
Yeah, I also wanted to stress indeed that there's a growing group of young people that are experiencing cancer and other conditions in which pain in acute situation is often an important side effect in a way. But also there's a growing group of young people who survive these kind of conditions, and pain is an often named symptom. That there's also often long lasting in nature, and it doesn't have to be, but it can become a problem. And at least here in Belgium, we see an increasing emphasis on the need for programs for these young people who have survived cancer, also concerning pain, because it's not my expertise, but it's is acknowledged that this group is different than what adults would need, also in terms of symptoms and complaints that last a long time. That's the thing that I wanted to add.
Yeah, and I think that's a very, very important comment you're making. I was also thinking about, you know, we in the new taxonomy, we talk about primary and secondary chronic pain. And there's a tendency sometimes to neglect the secondary chronic pain conditions. But for example, cancer survivors with remaining symptoms is a very important group, and it's probably a growing group since we're more and more successful in treating cancer. Unfortunately, they may have pain due to radiation or other, you know, procedures, or the cancer itself. But and here's my point, probably a bit controversial, but nevertheless, I think a lot of patients that have secondary chronic pain condition are held hostage in the system. We don't get access to these patients. They don't come to us. So they are being treated in that field of medicine where, you know, their primary problem belongs. But they do have chronic pain. And paradoxically, what interferes most with everyday life is likely to be pain and aspects that are related to pain. So these individuals do not get access to evidence-based interventions for chronic pain. And that's a shame. And we are probably not doing what we should as a team, if we talk about the healthcare system as a team, when it comes to providing these individuals with optimal possibilities to develop and become resilient and deal with their pain as adults. So I think when we have these adults with, you know, secondary chronic pain following cancer or arthritis or, you know, whatever it is, it's to an important extent a result of a failure within the healthcare system. We have not addressed the problem when we should have addressed the problems because we have not communicated and collaborated within the healthcare system.
Very well put, very well put. Does anyone else want to add anything to that question before we move on?
I agree completely, because we also see it in adults, and it's also a problem that is underestimated and unknown also to healthcare providers. Well, at least we see that cancer is often the focus, and that's a good thing that we become more successful in finding the right treatment. But once the treatment is over and a patient is healed to some extent, the problems that are long lasting are often ignored. That's not a conscious thing, but that's the way it happens, and people are lost also with their or I don't know, sometimes very frustrated because everyone expects them to go on with their life, but they can't because they have long-lasting symptoms, but they do not get the help and the support that they need. And we know because there exists evidence-based treatments also to assist these people and to decrease the suffering. But I agree completely that it starts with not diagnosing, not assessing very well, and not referring these people to the people that are specialized in these things. Yeah.
Fantastic. Thank you very much. Fantastic. So just another question. It reads, is there a difference in the pain experience of the child of natural birth compared to cesarean birth? Perhaps looking at neuroproprioceptive system development. Would we expect to see any differences between those two types of birth?
I think that's a good question, but I don't have the answer to it.
Difficult,
It's
right?
like good new paper, good new study to explore. No idea actually if there is literature on that. But yeah, good question.
Yeah, I mean, I would, of course, we need to be very careful when we talk about these things where we don't have a solid empirical answer to it. But I would like to say that even if there are, distinct groups of individuals, the variation within those groups are likely to be larger than the differences in mean within those groups. So I would say potentially at a group level, there may be, and that's something that we don't really know, I would say. But how clinically meaningful that difference in kind of average pain reactivity or pain responses, I would say maybe not the most important difference. There are other factors that have a more important clinical bearing.
Mm-hmm. Other things that might contribute to the picture a little bit more than perhaps that. Great stuff. Another question from Yolanda. Is there nowadays a growing amount of adolescents that have persistent pain in many body areas? So, for example, multi-site pain in an example given here, the musculoskeletal system. Is that becoming more and more common?
I'm not sure if I can answer the question if it's more and more common. I just know it is common, like most adolescents in our studies would describe that they have pain in multiple locations. That would be the majority of adolescents. I'm not aware, or I don't feel confident to say if that has been increasing over the years or if that has always been the case, but it definitely is a common thing that they have pain in multiple locations.
Mm-hmm. I think there's another research study that could be done, and the review of all the prevalence sort of studies led by Sarah King in 2011, right? So we need to, and I know that sounds awful, right? That you think like we just did it or they just did it. I wasn't part of it. But we need to probably revisit it. Somebody needs to, or actually look specifically in terms of at multi-site. Clinically, anecdotally, I wouldn't be surprised based on referrals to our clinic, but that's not empirically backed up right now.
Yeah. And 2011 doesn't seem that long ago, right? We already need to update this, but it sounds like people have got lots of ideas about things to further explore, and perhaps these things might come along in the next couple of years, perhaps. Just going back a little bit about building resilience in this population with regards to pain, could anybody touch on why might focusing on meaningful activities be perhaps more effective than addressing the specific aim to achieve a reduction in pain itself? Maybe Emilian, you could start, just explain kind of why that might be important and perhaps how people could go about that.
Well, I can refer to some studies that I did a long time ago during my PhD. I was on coping with pain, and we saw some differences between people. Some were found to be stuck in a way in trying to find, these were people with chronic pain experiences. Some were found to be stuck in trying to solve the pain. And it was often found to be, at the cost of other activities in their lives, of other things they wanted to achieve. It was like kind of a vicious circle in which they were stuck in. Their main goal was to get rid of the pain, in fact, at the expense of other things. And but it's broadly said, there is a lot of variation, in fact, but there was yet another group who kind of managed to build their lives despite the fact that they had pain. And it kind of links very nice with current treatments that are available and that I often use, and a lot of my colleagues also use in practice. When I see people, they often have a long history of many treatments, medical treatments and all these things. And the main thing that they say is, I really hope that they will find a solution. I want to get rid of my pain, but it costs a lot. It costs time, it costs effort, and all these things. And it causes a lot of frustration because you seek something that is in fact insoluble in a way. And the thing that I always say to people, and that was confirmed a little bit in research as well, that it's not the case that you don't have to seek for solutions to, I don't know, relieve your pain, but when it becomes the focus of life, when it becomes your focal goal, then it becomes a problem. It might become a problem because then it's I don't know, like your life kind of stops in a way. I see a lot of patients that don't take much initiative anymore in trying to achieve other things in life. And then we kind of, by using some of the treatments like things from acceptance and commitment therapy, that's the thing that you want to get people to get out of this vicious circle of trying to avoid something that is in fact not entirely, you cannot avoid it in a way, because pain is there and it will probably always be there in a way, but try to seek for ways to get to know your values in life, to get to know how you can approach these values despite the fact that you have pain. And this is, for me, this is kind of building resilience. Yesterday I had a client who I saw for kind of 8 months or something, and it's kind of the end of the treatment, and it's not about that he is relieved from his pain. He said, well, I still have pain, but it doesn't bother me anymore. I know who I am, in fact. I know what I want a bit more, and I'm confident that I can deal with the pain, and that I can set goals in order to build my life. So that's the thing I want to add. But I'm sure that my colleagues want to add as well.
I think it's very important to think about, like, when do things happen? When we have a very resistant type of symptom, like a persistent pain type of problem, it's unlikely that we will, push a button and pain will go away. So after a solid assessment and some of the interventions that normally have been tried before that adolescent or kid come to people like us, what can be done and should be done to reduce pain has already been tested based on the idea that the mechanism is addressable. So they're normally experiencing a pain with a different type of mechanism that is not possible to just address directly. So we end up in a situation where we look at how pain interferes with everyday life. And then, as we talked about, that leads to an avoidance cycle, or like a cycle with dysfunctional behaviors being displayed. And it leads to a trajectory with vicious cycles and downward spirals. And then when we start the journey, what we do, we focus on what is possible to control. And the symptom itself is very hard to influence or control, but there are voluntary behaviors. Some of the reactions from a behavioral perspective, we talk about reflexive behaviors as behaviors too, but responses are sometimes tricky to directly just take control over and change. But the operants, the voluntary behaviors, they can be addressed. So what we do is we start focusing on things that we have control over. And starting to behave differently will result in different outcome. So over time, we start to increase the ability to do things that are important in the presence of pain. And by doing that, which we would refer to as exposure, we gradually change our relationship with pain. We get more and more experiences from situations where we did things that didn't feel comfortable or possible, and the threat value starts to change. So an aspect, an important dimension of the pain, maybe the most important dimension of pain, actually is gradually changing. But, and here's like my point, it starts with behavior change and results in a modification of the symptoms, of the experience of the symptom. It doesn't go the other way around. Mm-hmm. So it could well be that we have a change in the pain experience, but very important to sort of realize that the journey starts with behavior change. And then you see, as a result of that behavior change, indirectly, you will alter the stimulus function of pain, or you will alter the way pain is experienced.
Yeah. No, that's fantastic. And, you know, that's a great way to summarize everything that we've been talking today. And I've just looked at the time and it's absolutely flown by. So unfortunately, we will have to end it there with regards to questions and responses. But what a great discussion. Thank you so much for everybody for the questions in the Q&A, and obviously to the speakers for taking time today and asking each other questions to facilitate those discussions. There was really some interesting points. Again, the aim of these webinars are to facilitate that discussion and talk about important topics and perhaps maybe take steps further to better management for the population that we're talking about. So again, thank you to all the attendees for the brilliant questions and to the speakers for taking time to answer, as I mentioned. So as I mentioned previously, this webinar is recorded, so everyone should be able to access this recording on the EFIC Academy platform. So check out the EFIC Academy education platform, obviously, for more content. And again, we'll have to end it there. Thank you so much for everybody taking time today, and have a fantastic rest of your day.
Thank you. Thank you.
Thank you so much.
Thank you.
Bye.
Bye.